Today, we are going to see about the periodontal diseases in children. It was on October 30, 1999, that American Academy of Periodontology assembled an international workshop for the classification of periodontal diseases and conditions, which resulted in a new classification. Thus, periodontitis or periodontal diseases discussed here will reflect the newer classification system. Clinically distinct periodontal infections that can affect young individuals include dental plaque-induced gingival diseases, chronic periodontitis, aggressive periodontitis, periodontitis as a manifestation of systemic diseases, and necrotizing periodontal diseases. So basically, periodontitis is the inflammation of gingiva and the adjacent attachment apparatus, and it is characterized by the loss of connective tissue attachment and alveolar bone. So basically, the classification includes, as said before, dental plaque-induced gingival diseases and the various forms of periodontitis, which include the aggressive, chronic variants, as along with the periodontitis seen as a manifestation of systemic diseases. So the clinical features generally include presence of periodontal pockets, bone loss, bleeding, gingival inflammation, etc. It is characterized by a slow to moderate rapid or rate of progression. Furthermore, the severity of disease could be either mild, moderate, or severe. That is, referring to more than or equal to 5 millimeters of clinical attachment loss. So, coming to the details. First one, we'll see about the aggressive periodontitis. The primary features of aggressive periodontitis include a history of rapid attachment and bone loss with familial aggregation. Secondary features include phagocyte abnormalities and a hyperresponsive macrophage phenotype. So generally, they can be classified into localized or generalized. Localized aggressive periodontitis. These patients have interproximal attachment loss on at least 2 permanent first molars and incisors, with attachment loss on no more than 2 teeth other than first molars and incisors. They are seen generally in children and adolescents without clinical evidence of systemic disease, and it is characterized by the severe loss of alveolar bone around permanent teeth. Frequently, the disease is localized to the permanent first molars and incisors. But there are some data which are obtained from these localized patients suggest that bone loss around the primary teeth can be an early finding in the disease. Even this has been seen associated with a gene conferring increased risk for the condition on chromosome 4. Coming to generalized aggressive periodontitis, these patients exhibit generalized interproximal attachment loss, including at least 3 teeth that are not first molars and incisors. In young individuals, the onset of these diseases is often circumpubertal. Usually, the localized form appears to be self-limiting, while others suggest that it is not. Some patients initially diagnosed as having LAGP were found to have the generalized variant or to be periodontally healthy at a 6-year follow-up examination. So this condition shows the presence of subgingival sites which are harboring non-motile, facultatively anaerobic gram-negative rods, including Porphyromonas gingivalis. So the necrotizing periodontal diseases that which is the next type. They occur with varying but low frequency. There is less than 1% in the North American as well as the European children. It is seen with greater frequency, that is 2% to 5% in certain populations of children and adolescents from areas like Asia, Africa, and South America. The two most significant findings used in the diagnosis of this condition are one, the presence of interproximal necrosis and ulceration. Second is the rapid onset of gingival pain. Patients with this condition can often be febrile. Necrotizing ulcerative gingivitis or periodontitis sites harbor high levels of spirochetes and Protella intermedia, and invasion of the tissues by spirochetes has been shown to occur. Factors that predispose the children to this condition include viral infections like HIV, malnutrition, emotional stress, lack of sleep, and a variety of systemic diseases. Treatment generally involves mechanical debridement, oral hygiene instructions, and careful follow-up. Even has been found that debridement with ultrasonics to be particularly effective and resulting in rapid decrease in symptoms. If the patient is febrile, antibiotics may be an important adjunct to the therapy. Metronidazole and penicillin have been suggested as drugs of choice. So, generally, you can see that the alterations in immunological factors such as immunoglobulins are known to be present in aggressive variants. Like immunoglobulins, they appear to influence by both genetic as well as environmental factors, and they have very important protective disease limiting factors in aggressive variants. Even the human immunoglobulin G antibody molecules are categorized into 4 subclasses, and most of the antibody reactive A commitants is specific for high molecular weight variant. So this antibody response appears to be protective, as early onset periodontitis patients have high concentrations of this antibody reactive A commitase polysaccharide, having significantly less attachment loss and patients who lack this antibody. So, coming to the management part, the successive treatment often depends on early diagnosis, directing therapy against infectious microorganisms, and providing an environment for healing that is free of infection. While there is some disagreement among the studies related to the treatment, most recommend a combination of surgical or non-surgical root debridement in conjunction with antimicrobial therapy. These findings often are supported by other work, which includes repeated mechanical therapy with antibiotics, especially to arrest most cases of the localized type. But the surgical treatment may also be effective in eliminating A commitants without the use of antibiotics. So, chronic periodontitis, which is most prevalent in adults, can occur in children and adolescents also. The classification, again, very, very important, like the severity of disease classified as mild with 1 or 2 millimeters attachment loss, moderate 3 to 4, and severe more than or equal to 5 millimeter attachment loss. Coming to the periodontitis, which is seen as a manifestation of systemic diseases. In patients with one of several systemic diseases that predispose to highly destructive disease of primary teeth, the diagnosis as periodontitis is a manifestation of systemic disease. As with adults, periodontitis associated with systemic disease occurs in children and adolescents. Such diseases include Papillon-Lefebvre syndrome, cyclic neutropenia, agranulocytosis, Down syndrome, hypophosphatasia, and leukocyte adherence deficiency. So it's probable that defects in neutrophil and immune cell function associated with the diseases play an important role in increased susceptibility to periodontitis and other infections. Generally, in cases with Papillon-Lefebvre syndrome, teeth erupt in normal sequence, but the symptoms start to appear when the primary teeth start to erupt. The gum tissue is seen severely inflamed. Generalized periodontitis may accompany the eruption, And by age 4, the child would have lost all the primary dentition. And by the time the eruption of permanent dentition occurs, usually at around the normal age, following the normal sequence, patient will start losing the permanent teeth and will become completely edentulous at around the age of 18. Shirya-Higashi syndrome, which is a rare autosomal recessive disorder that which is characterized by abnormalities in the cytoplasmic granules, primary defect which is seen affecting the neutrophils, along with the clinical features like partial albinism, bleeding disorders, recurrent bacterial infections. We'll be able to identify the presence of rapidly destructive type of periodontitis, where the bone loss is usually generalized and severe, and the patient may not be responding to periodontal therapy. In Down syndrome, the amount of periodontal destruction has been shown to be positively correlated with the severity of neutrophil chemotaxis defect. And in some cases, specific genes may be associated with these diseases. Like in C, the cathepsin C gene and Papillon-Lefebvre syndrome are associated. Also, the tissue non-specific low alkaline phosphatase gene and hypophosphatasia. So generally, periodontitis as a manifestation of systemic disease in children is a very rare disease that often begins between the time of eruption of primary teeth up to the age of 4 or 5. Disease occurs either in localized or generalized forms. In localized form, affected site exhibit rapid bone loss and gingival inflammation, that too but the minimal amount. In generalized form, there is rapid bone loss around nearly all teeth and marked gingival inflammation. Neutrophils from some children with a clinical diagnosis of periodontitis as a manifestation of systemic diseases have abnormalities in relation to cell surface glycoprotein like leukocyte functional antigen 1. And neutrophils in these patients have leukocyte adhesion deficiency, and they're likely to have a decreased ability to move from circulation to sites of inflammation infection. Again, the affected sites harbor elevated percentages of A. comitans, Prevotella intermedia, A. canella corrodens, and capnocytophagum. So generally, the treatment of periodontitis as a manifestation is similar to the treatment of localized and generalized aggressive types. Like localized lesions could be treated successfully with the approach, but the degree of predictable success in managing the generalized type is low when systemic disease are the contributing factors. In many cases, you can see that the affected teeth need to be extracted. So generally, they require a periodontal examination, that is extra and intraoral examination to detect the periodontal or diseases or conditions. General, to evaluate the topography of gingiva and related structures, such as the probing depth, recession, and attachment level. To evaluate the health of subgingival area with measures such as bleeding on probing and suppuration. Next would be the assessment of presence or degree of distribution of plaque, calculus, and gingival inflammation. Dental examination may include caries assessment, proximal contact relations, the status of dental restorations, prosthetic appliances, and other tooth or implant related problems, determination of the degree of mobility of teeth and dental implants, occlusal examination, interpretation of satisfactory number of the updated diagnostic quality periapical and biting radiographs may be needed for implant therapy, along with the evaluation of potential periodontal systemic interrelations. And there should be an assessment done to see the suitability to receive dental implants. So generally, the treatment procedures include the use of chemotherapeutic agents. These agents may be used to reduce, eliminate, or change the quality of microbial pathogens or alter the host response through local or systemic delivery of appropriate agents. Resective procedures are designed to reduce or eliminate periodontal pockets and create an acceptable gingival form that will facilitate effective oral hygiene and periodontal maintenance treatment. Soft tissue procedures include gingivectomy, gingivoplasty, and various mucogingival flap procedures. Osseous procedures include ostectomy and osteoplasty. Dental tissue procedures include root resection, tooth hemisection, and odontoplasty. Combined osseous and tender tissue procedures may be required for management of endodontic and periodontal lesions. Periodontal regenerative procedures include soft tissue grafts, bone replacement grafts, root biomodification, guided tissue generation, and combinations of these procedures for osseous furcation and precision defects. Periodontal reconstructive procedures include guided bone regeneration, ridge augmentation, ridge preservation, implant site development, and sinus grafting. Occlusal therapy include minor tooth movement, occlusal adjustment, splinting, or provision of devices to reduce occlusal trauma. So, in summary, children and adolescents are subjected to several periodontal diseases. Although there is a much lower prevalence of destructive periodontal diseases in children than adults, children can develop severe form of periodontitis. In some cases, this destructive disease is a manifestation of a known underlying systemic disease. In other young patients, the underlying cause for increased susceptibility and early onset of disease is unknown. These diseases are often familial, suggesting a genetic predisposition for aggressive disease. So, current modalities for managing periodontal diseases of children and adolescents may include antibiotic therapy in combination with non-surgical or surgical therapy. Since early diagnosis ensures the greatest chance for successful treatment, it is important that children receive a periodontal examination as a part of their routine dental visits. These are the references. Thank you.